My topic is a whole day topic, but I only get 15 minutes, so please bear with me. I'm going to keep it very, very simple. I'm going to keep it very, very simple. And probably a little bit interactive as well. So, thoracic trauma kills patients. Okay? It kills instantly sometimes. That's the most important thing. You can learn a lot about other kinds of trauma, other kinds of GI surgery or other plastic or other things, but thoracic trauma will kill. So I just got a US data. There's a lot of patients die every year due to chest trauma, and there's motor vehicle accident where nearly 50% fatality of those who die in metabolism. 50% of them are due to chest trauma. Okay, so in Nepal, say roughly, there are probably about 9 thoracic surgeons. If you go to Pokhara, Dharan, Biratnagar, Brigan, Budwal, Nepal, there are 0 thoracic surgeons. 0. Okay? And I get a lot of referrals from other centers saying, we cannot handle this, please take care of this. Okay? And if you are trained and you go out in the periphery, you will be dealing with thoracic trauma. Okay? And I'll give you a nice example. So when Dr. Govind Kesi was tried to be brought to Kathmandu, there was a big scuffle, as you might all know, and then the poor policeman got I think, pierced by a glass. And I'm told, I cannot verify this story, I'm told, this is the first time I knew, that someone had to do a thoracotomy in Jumla. And they were still bleeding. They said it was from the right atrium. I don't think it's in the right atrium. I think the patient would be dead if it was the right atrium. But bleeding could not be controlled, so they packed it and then sent it to Kathmandu. I don't know what happened to the police after. So that's your scenario that you see. Okay? So whenever you talk about thoracic trauma, you'll be talking about X-ray. Okay? I'm not going to show you features of what an X-ray looks like, what it is, what it is. That's medical school. Okay? But as a resident, you have to be perfect in looking for what do you want to look for in a chest X-ray. And these are the things you need to look for. Okay? If you miss a pneumothorax, you should not be a surgeon. Okay? Simple as that. If you miss a pneumothorax, you shouldn't be a surgeon. Okay? And other things like mediastinous shift, apical gaps, due to major bleeds, rib fractures, scapular fractures, first rib, all these different kind of features, the fine, subtle features that you can see in X-ray. Okay? That can make a difference between life and death. Okay? And you have to learn to read an X-ray very, very perfectly. Okay? And I even tell the trainees, if you don't know X-ray, take it to your bathroom, put it in the back wall of your bathroom, and then we'll look at that X-ray till you finish your bathroom. Okay? Then you can practice and practice and practice. So, and obviously, you should have a very, very small threshold for a CT scan. Okay? Any CT scan, get a quick CT scan, low-dose CT scan, non-contrast CT scan. If you can get a contrast, even better. But if you can't get a contrast, non-contrast is fine. That'll give you a 3-dimensional lot of information about what's happening. Okay, so there are many types of scenarios in chest trauma, and I need a whole day to talk to you about all of that. But 80%, 90% of the time, you'll always get multiple refractions. That's all you get. Okay, and for today, let's just concentrate mostly on refractions. Okay, I'll talk a little bit about other things as well. And there's no need to RTA, someone is hit by a bull or something like that. So how do you manage multiple refractures? Okay? The important thing is breathing. The patient will not breathe well. And if he doesn't breathe well, it retains the secretions, the lung collapses, and you get all kinds of pneumonia, ventilator, sepsis issue. People have died in many major hospitals because their lungs did not work. Comes with simple lung rib fracture, stays in ICU, doesn't get proper physiotherapy, and then end up with all of them and they're dead. Basically. Okay, this has happened again and again and again. So don't take it lightly. Okay? And as a surgeon, you need to not only have your hand-eye skills, you need to have your critical care skills perfect as well. Okay? Okay. So about controlling pain. How do you control pain? Okay, there are many ways of controlling pain. Okay, and these are the things. You get these slides later on. I'm not going to go back through it. But make sure your pain is controlled well, very well. Okay, mobilize well, good respirator, frequent coughing. A lot of physiotherapy. You need to be a physiotherapist while you are being a surgeon as well. You need to be a critical care specialist while you are being a surgeon as well. This will make you a better surgeon. Okay, so those are things that you need to know. Know when to do suction. learn the art of bronchoscopy if you can. It's not very difficult. Okay? Anybody can do bronchoscopy. And obviously then you coordinate with your anesthetic team very, very closely. So you cannot give intercostal blocks. I've been to ICU, the patient is screaming in pain, sitting down. Nobody's doing anything about it. The nurse is sitting there watching on the screen. The resident is not available. Patient, all you do is take some lidocaine, inject it in the rib, hit the rib, go underneath the rib, inject it. Patient instantly feels much better. Okay? And then it breathes well. Okay? And then you talk about TENS and then epidural thing. You have to coordinate very closely with your anesthesia. I see this very, very regularly, and it's inadequate in multiple hospitals in Kathmandu, and forget the rest of the country. Now let's talk scenarios with multiple rib fractures. Okay, so patient gets transferred from these are real things that has happened to me. Okay, so I'm just going to give you some example. So patient gets transferred to a big hospital from the periphery after massive hemothorax. He's already had a drain placed. Okay, and the drain has drained a liter. What do you do next? I want to make this little interactive if you have time. Would anyone like to say anything? Just shout if you want. What is going in your mind? You'll see this. You go to our periphery, you'll get this. You put a dress drain and you get a liter of blood out. What's going to do? What are you going to do? Nothing. Just watch the blood. Watch the blood. Watch the blood. And so, if the patient is lucky, okay, the answer to the question, and if you get this in your MS question, you say, if this question comes and say, what are you going to do? I need to make sure the patient is stable first. That's your answer. Okay? So make sure your vitals are stable, your hemodynamics are very stable. This is a hemorrhagic shock to start with. Okay? So make sure your vitals are stable, your hemorrhagic shock is controlled. It might be an open tap, something is bleeding inside and does not stop. No matter how much blood you pour in, something is going to come out through the drain anyway. It might be. Most of the time it is not. Most of the time it will stop. Okay? A lot of bleeding will stop. Okay? Even major bleed, if you need a tear in the aorta or something like that, it will just stop. It will make a hematoma on top of it, it will stop. Okay? So hang on for a while. Okay? Hang on. Make sure your hemodynamics are stable. Okay? And then if you are really troubled, then you might need to decide whether you need to do a thoracotomy. There is no fixed rule. Some people say if 200 ml comes out every 2-3 hours, take it out. Some say 300. We've watched people who've had a liter of blood coming out. The question is, when did the trauma take place? Okay? If the trauma took place one day ago and you put a drain after 24 hours and the liter of blood comes out, that's a very different scenario from putting a chest drain half an hour before it happened and a liter of blood comes out. Okay? Those are two different scenarios, and you have to know the time scale, because things might have accumulated over time and then the blood has come out. Okay. We very rarely have had to go in and do a big thoracotomy for major bleed, at least in my experience. But you have to keep an eye. So this patient comes with massive hemothorax, drain, he keeps in ICU for a couple of days. The hemothorax now has converted into a clot, and that clot has pushed on the lungs and now has trapped the lung, and that lung is not expanding. Okay? And then you're sitting there with an unexpanded patient is struggling to breathe, lot of pain, fracture all over the place, and that clot can now convert into a pus, it can convert into a fibrothorax, it can convert into anything now. Okay? You have to do an elective thoracotomy to remove all the clot and let the lung expand. So understand the physiology very well here. Okay? So that's what we did. Ultimately, we ended up doing a thoracotomy. Later on, after the patient was stable, after all the clots were taken out, we do a deportation. So now we've got another scenario. Patient gets admitted simply due to pain discovered. He moves to ICU from one bed to another bed in ICU, and then he suddenly has a massive subcutaneous emphysema. The key word is subcutaneous. Okay, now people say surgical emphysema. Surgery is not the key word. The key word is subcutaneous emphysema. And so you put a chest drain. There is still a massive air leak. What do? You watch the air leak. You watch the blood. You watch the air leak. What do you do?
Another large chest tube.
I like that answer. Okay? I like that answer. So the question is, the lung is inside a drum. Okay, so you have a balloon inside a drum. That balloon needs to expand and fill the drum. Once the drum is filled, it will touch the lung will touch the chest wall and will seal everything. If it's blood, it will seal the blood. If it's air leak, it will seal the blood. that lung has to expand. Okay, that's the important thing. To expand that lung, if you need to put one drain, you put. If you need to put two drains, you put two drains. It doesn't matter. Okay, but that lung has to expand. How do you know the lung is expanded? Number one, you put the drain, you put it on low pressure suction. You suck the blood, you suck the air, create a vacuum, and you can do spirometry, all that if the patient can tolerate it. Okay, and if that doesn't work, then you have to decide what else. Most of the time, it's fine. You don't need to put a second drain. In my career, maybe I put a second drain only once in my life. So, but you have to understand the concept behind the thing. Okay, you do what's called I will use the word talan. Okay, you make the lung touch the wall and you seal it up. Okay, whatever way you do it. So that's important. I'll come back to this now. So now I've got a third scenario. You've got a fractured patient who's under GA, fractured tibia. And this is a multiple rib fracture. All these happen with multiple rib fracture. Okay? This is in the middle of the operation, the saturation falls. What could be happening? We discussed this a couple of days ago. What is happening? Check the airway. Okay. So this patient does not have a chest tube. His chest tube is removed. Okay. But what is happening? What do you think is happening? Two things might be happening. Okay. What are the two things that might be happening? I don't like that answer, sorry. With apologies, with due respect. So, if something is happening under GA and the airway and the saturation falls, your first thing is to see if the tubing is okay. If the tubing is okay, if there is a kink in the tubing, is the saturation profile, has the oxygen level dropped, is our central oxygen supply gone? This is the headache of the anesthetist. It's not your headache, but it is also your responsibility to know what's happening around your environment in the outpatient. Because by the time that TBI is fixed, the patient will be dead. Okay, if you cannot sort it out. Okay, check your tubing first. And if the tubing is okay and still the saturation falling in a multiple rib fracture patient without a drain, what could be happening? It's very simple. What could be happening? Any answer, even if you are wrong, don't worry. Don't. Why?
Positive pressure regulation.
You are getting there. The peak pressure causes the lung to expand even more. Okay, it fills up. The balloon fills up, but now it's got spikes inside the lungs. Okay, in the chest cavity, the ribs are broken. It's got spikes all over. That spike is going to hit an inflated lung and cause air leak after air leak. It's going to puncture the lung. Okay, and then the patient is in peak pressure, okay, and there's air now building up inside the chest cavity. There's a massive pneumothorax, and nobody knows about it. Patient is asleep. All you see is a saturation dropping. What do? Put a chest tube, okay. Put a chest tube. You can put a blind chest tube, okay, on the side where the rib is fractured. Sometimes there are situations where if you put a chest tube on one side and it doesn't work, you can put a chest tube on the other side. Do not be afraid to put a chest tube. Just a small vent is fine. Sorry, it's going long. So, this is the rib fracture scenario. 80%, 90% you get a chest trauma for this. Other is now the esophageal perforation. So, this is what happened to me basically. Okay? Patient got transferred from a peripheral center and with the chest tube with the draining pus. The history is that she swallowed a chicken bone and caused a hole in her esophagus. We know there is a hole in the esophagus. Okay, what do you do next? This is not an acute chest trauma, there is still a chest trauma. There is a chest tube. And there is draining pus. What do you do? Someone must know. The thing is, you have to close that esophageal hole. Okay? How do you close that esophageal hole? Don't tell me you do a thoracotomy. Don't tell me you do a thoracotomy. You can do a thoracotomy. You should probably end up doing it in the future. Sorry? I can't hear you. Shout. You got an infected chest cavity with pus all over and you got a hole in that esophagus. Okay? Whatever you're going to go to do, you're going to be very careful. You don't think that you can go and put a stitch in that esophagus and it'll be fine. This very inflamed, angry esophagus. It's like an inflamed appendix. You cut and it starts cutting and cutting and cutting. You can't let it go. What can you do? I like that answer. Okay. So in this age and technology, in this age and technology, and especially when you graduate and become senior surgeons, you will have that technology. It is available at this point. It's expensive, 60,000-70,000, but it's available. Okay. So we put an esophageal stent. Okay. After we put an esophageal, we stabilize the hole. Okay. And then we transfer the patient. We did a right thoracotomy and did complete decortication and remove the pus and cause the lung to expand. Okay. And clean that air cavity. Patient was discharged actually well, and then after 3 months the stent was removed. Maybe the whole cost of doing a big operation for esophagus, you can pull the esophagus, you can make a hole in the esophagus, you can put a Ennis fistula here, and all that. It will probably end up costing you 50,000 anyway. Okay, so a stent is not is expensive, but I don't think it's cheap. It's not cheap, but I don't think it's expensive as well. But that technology, you have to have a very good relation with your GI surgeons, or as well as your gastroenterologists who are skilled in this technique. Diaphragmatic injury can happen. You can do either thoracic or abdominal approach. I think now there's more tendency for abdominal approach these days, and it's very easy. Okay, so you've got a massive supplement. This you see this again and again and again. Okay, large area comes from the lung parenchyma, usually rarely from a tracheobronchial fistula. I get phone calls saying, "Oh, this is a bronchopleural fistula." It's not a bronchopleural fistula. This is a parenchyma fistula. Okay, and that's very, very important. Assure the family. This family is scared. It's very, very scared. Having a subcutaneous with the face swollen like this is very, very scary. Communication is a very important part of your surgical training. Okay, and assure them that this is not life-threatening. They think the patient is going to die with the face like this. Half an hour ago he was fine. After half an hour, his face is looking like a balloon. Nobody knows what's happening. It's very simple. Put a chest drain. Make sure the air is coming out properly, and assure the patient that this will settle down. And make sure your saturation and vitals are stable. Flare chest. I won't talk very much about it. You make sure your airway breathing circulation is fine. You give painkillers. You give CPAPs. Okay. And if that doesn't work, then you have to give ventilation. Very rarely you have to internally fix the patient. Okay. They usually settle down. The problem is not only about the dynamics of the rift wall, it's also about the contusion on the lung, and that you have to give time. Do not be afraid to do a thoracotomy, okay? Do not be afraid. It's just a cut in the chest, you cut it open, okay? And you have to look inside. Okay? And you can do a thoracotomy in the emergency department as well. So, when it comes to a life-saving thing, just slash your knife, get inside it, and find the problem. You can do what's called a clamshell thoracotomy. You just cut straight across the rib through the sternum, through the other side as well. Okay? And your exposure will be perfect, beautiful exposure. You see the problem. This wound will heal very, very well. You don't have to worry at all. Always inspect the back. Okay? So in summary, chest trauma can heal very, very, very quickly. Always learn to eyeball a stable and unstable patient. Okay? Do not leave a patient with a heart rate of 120 and say, "Oh, he'll be fine. Maybe so he's in pain. Maybe he's anxious." It's not acceptable. Look for causes. Okay? Make sure the saturation is okay. Do not accept that, okay, saturation 89, 90 is fine. It's not fine. And if a patient is stable, don't walk away. Make sure you are being checked, rechecked again and again. Okay? All this tamponade, tension pneumothorax, ongoing pneumothorax will be stable to start with, but then they'll deteriorate afterwards. Thank you very much.